I am Dr. Risa Kagan, and I'd like to welcome you on an update on bone health sponsored by the International Menopause Society. I'm your moderator here today, and I am a clinical professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at the University of California in San Francisco. I'm also a practicing gynecologist and a clinical researcher with Sutter Health. And I am also on the Scientific and Medical Advisory Board of American Bone Health. And I'm happy to moderate the session on an update on bone health with Dr. Stephen Goldstein, who will talk to us about the burden of disease, followed by Dr. Tobie de Villiers, Osteoporosis, Treat to Target. And then Dr. Goldstein will finish with the contribution of muscle and the link to sarcopenia. And then I will be happy to moderate all of your questions. Just type them into the chat, to the question box. Professor Stephen Goldstein is a professor of obstetrics gynecology at NYU in New York City. He is current president of the International Menopause Society, director of gynecologic ultrasound at NYU Langone Medical Center, and is one of the most highly recognized and regarded individuals in the field of gynecologic ultrasound. He's authored more than 60 chapters of textbooks, as well as 80 original research articles. He's been a guest faculty member, invited speaker, visiting professor, and course director over 400 times throughout the United States and actually internationally. And Dr. Tobie de Villiers is a consultant gynecologist with a special interest in gynecologic endocrinology, menopausal medicine, and osteoporosis. He graduated from the University of Stellenbosch, Cape Town, South Africa, and holds the following qualifications and degrees: FRCOG and FCOG from South Africa. He's the past president of the IMS, and he is actively involved with research in the field of osteoporosis and menopause. He has authored various recent peer-reviewed publications and chapters and textbooks, and regularly reads papers and he presents papers at national and international meetings. So with that, I'd like to introduce Dr. Goldstein, but prior to that, I want to also remind all of you that this webinar is supported by an unrestricted educational grant from Besson's Healthcare. And I can assure you that they had no role in the selection of the topics, the speakers, and have not seen or vetted any of the content of these presentations. So I hope you enjoy this webinar.
Well, thank you very much, Dr. Kagan. Let me see about sharing my screen. Okay, can you see that, I hope? Excellent. So what I'd like to introduce here is really the burden of osteoporosis, poor bone health, and fragility fractures. Worldwide, osteoporosis causes more than 8.9 million fractures annually, and that translates into an osteoporotic fracture every 3 seconds. It's estimated that osteoporosis affects 200 million women in the world, 1/10 of women age 60, 1/5 of women age 70, 2/5 of women aged 80, and actually, by the time a woman gets to be 90, 2/3 of those women will carry this diagnosis. Worldwide, 1 in 3 women after the age of 50 will experience an osteoporotic fracture. At menopause, the removal of estrogen has much greater effects, excuse me, in women than men of similar age. The female to male ratio for an osteoporotic fracture is about 1.6 to 1, such that 80% of forearm fractures, 75% of humerus fractures, 70% of hip fractures, and 58% of spine fractures will occur in women. A prior fracture is associated with an 86% increased risk of any subsequent fracture. Fragility fractures are a leading cause of chronic disease morbidity. For instance, in Europe, fragility fractures are the fourth leading cause after ischemic heart disease, which is number one, dementia, and lung cancer. However, fragility fractures surpass chronic obstructive lung disease, pulmonary disease, COPD, and ischemic stroke. After sustaining a hip fracture, about 10 to 20% of former community dwelling patients will end up in long-term nursing care. Overall, hip fracture causes the most morbidity, and in fact, mortality rates in up to 20 to 24% of these patients occur in the first year after a hip fracture. Loss of function and independence among survivors is profound, with 40% unable to walk independently and 60% requiring some assistance a year later. I want you to contrast that with the early detection of breast cancer. In localized breast cancer, where there's no sign that the cancer is spread outside the breast, the 5-year survival in the United States is 99%. Even in regional breast cancer, which is defined as spread outside the breast to nearby structures or lymph nodes, in the US, there's an 86% 5-year survival. So in developed countries where women have access to periodic, competent breast screening by imaging techniques, for many of these patients, the diagnosis of localized breast cancer and the psychological ramifications may actually exceed the physical manifestations. In my clinic, almost all women are cognizant of breast health, have a great fear of breast cancer, and for the most part are attuned to the importance of competent periodic breast imaging, which clearly is the key to the earliest detection. My goal is to get these same patients to be just as concerned about their bone health. And notice, I do not say simply low bone mass or poor T-scores on DEXA, because as we will discuss, I think there is a lot more to bone health than simply what's your score on a DEXA scan. I want to get them just as concerned about their overall bone health as they are currently about their breast health. And why? Well, I think it's easy. If you contrast the statistics that I just went through vis-a-vis breast cancer versus the statistics cited about the incidence, morbidity, and even mortality associated with osteoporosis and fragility fractures, the answer to this why question becomes obvious. So with this in mind, I'm now going to invite Professor de Villiers to discuss osteoporosis with an emphasis of treat to target. You're muted. There you go. Tobie, you're muted. Tobie, muted.
So de Villiers, if you explain the problem.
Okay, I just want to get this off and there. Okay, can you see my screen now?
Yes, we can.
Okay.
But
And you see that now?
yes, perfect. Thank you.
Okay, sorry for that little hiccup there. Technology doesn't always work the way that you anticipate it to do. And thank you very much, Steve, for describing us the scope of the problem. And that is exactly the reason why the Board of Trustees of the International Menopause Society decided that the focus of this year's World Menopause Day should be on bone health. So what I'm going to try to do in the next 20 minutes is to give you a little idea about the clinical side of dealing with bone health, as I've been involved in this for the past 30 years plus, from a point where we started where we knew very little about bone health. So pivotal to this has been the understanding of the physiology of bone health. In 1993, we were helped a lot by the consensus development statement that actually defined osteoporosis for the first time as a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration, leading to enhanced bone fragility and a consequent increase in fracture risk. Well, up to this point, the diagnosis of osteoporosis had been basically, it was diagnosed when you sustained a fragility fracture. But now we had a definition of what precedes it. So don't be afraid of this slide. It looks very intimidating, but this is really all about what controls bone. In other words, the cycle, the resorption cycle. So, or the remodeling cycle. So what we have at the top here is the basic principle that old bone is taken away by the osteoclast and to be renewed by new bone. And the balance between these two processes determines whether you actually gain bone as supposed to be in the younger phases, or whether you lose bone after the postmenopausal time or the year of 50 in men. So there has been very important steps that have been defined. And the first one is the mevalonate pathway that actually energizes the osteoblast, as you can see with the signal there. And that's exactly where the bisphosphonates work, which were the first drugs that we had available in the 1990s. The second one is the rank ligand signaling pathway, which controls the crosstalk between the osteoblast and the osteoclast. And this is targeted by the biologic drug denosumab. The last pathway of great interest was the Wnt beta-catenin signaling pathway, which controls the osteoblast. And that is the step where all our anabolic drugs work. So recognizing these steps and these pathways since the late 80s has actually been very pivotal in the development of the field of osteoporosis. So the second important aspect that I would bring out is the identification of risk factors for fracture, because unlike what was put on the bread that I'm talking about, treat to target, I'm actually talking about the target to treat. Treat to target is something different. So I'm talking about the people which we should target who are at risk of fracture. So as I said before, that before the definition of osteoporosis, we called it the silent disease, but now we are able to identify it before. And the first risk factor for fracture that really made a big difference was the fact that we recognized that bone mineral density correlates better with an incidence of hip fracture than, for instance, cholesterol with myocardial infarction, and just as well as an increase in blood pressure and stroke. So once this was realized, we had an evolution and a revolution of new machines that could actually measure bone density in an easy and reproducible way with minimum ionizing radiation. And today's dual X-ray absorptiometry machines, or DEXA machines as we would call it, actually works amongst by a very easy mechanism. You have an energy source at the bottom of the table. The energy is then sent through the bony skeleton, and this then will be detected. The amount of radiation that proceeds through bone will then be detected by the collimator and the photon detector, and that will be then related by a computer into how strong bone actually is, depending on how much or how little of the energy is let through. And that then brings us to the T and the Z score that Steve has alluded to, where the T score will always explain the difference between the patient's value and the expected peak bone mineral density at about the late 30s, or the Z score, which will relate it to the peers of the same age. So just in a simple nutshell, we always use the T score in postmenopausal ladies and the Z score in premenopausal ladies. And in 1994, then, the field had another big leap when the WHO actually defined, using central DEXA, how we could define the patient at risk. So normal patients have a T-score of -1 or higher, and the 1 refers to 1 standard deviation. Low bone mass or osteopenia is between -1 and -2.5, whereas osteoporosis is equal to -2.5 or lower, and that can be with or without a fracture, which we'll allude to later. At this point, it's just very important also to realize that when we're talking about the Z score and premenopausal patients, we have a different definition, and low bone density is only diagnosed when we have a level T-score or Z-score of -2.0 or lower, and that in order to diagnose osteoporosis, you have to have a combination of low bone density and fractures. So according to these lines, although this WHO definition was never meant to be an indication for treatment, this has been a very common practice, and this is our what we use in South Africa from the National Osteoporosis Society of the Foundation of South Africa, that treatment should always be considered when a DEXA T-score is smaller or equal to -2.5 at the hip, and that could be either the femur neck or the total hip or the spine, whichever is the lowest. And it should also always be considered when a fragility fracture is present, and we're going to be talking more about that. The more difficult one is what to do with the patient with low bone density or osteopenia, and that's what we also will be discussing. So the clinical risk factors that identifies our target to treat will then be a low bone mineral density, as already discussed, a personal history of any fracture after the age of 50, but more specific, a fragility fracture. So we see that typical osteoporotic fractures would be of the wrist, the spine, the hip, the pelvis, or the foot, or the arm. The difference between a fragility fracture versus a traumatic fracture is a fragility fracture is defined as a fracture which occurs after a fall from own body height. We can also grade the severity of the fracture. As you can see here, we always compare the anterior portion with the posterior portion. And if that is a drop of between 20 and 25%, it is called a mild fracture. If, however, it is between 26 and 40%, it will be a moderate fracture, and the severe fracture would be more than 40%, as you can see here. It's very easy, even with the eye, to see the severe and the moderate fractures, where it's much more difficult to detect the mild fractures. We also now know that the amount of fractures correlates to future risk. Any fracture increases the risk of subsequent fractures. And what's always also important is the recency of the fracture. In other words, a fracture in the previous year has a greater risk than a fracture of 4 years ago. Other risk factors are advanced age. So for a T-score, a certain T-score at the age of 60, it will be a much worse prognosis if that is at the age of 80. Low body mass index, secondary causes such as an early menopause, the use of steroids, rheumatoid arthritis or diabetes, smoking, excessive alcohol consumption, a diet low in calcium and protein, lack of sun-side exposure leading to lack of vitamin D, or sedentary lifestyle are all clinical risk factors. Now, these factors have been validated in the placebo arm of most of the studies that were done in the development of our modern osteoporotic drugs. So in order to make any sense out of how these fractures or how these risk factors can be put together in order to predict the risk of fracture in the next 10 years, IMS supports the use of the FRAX tool, which was developed by the guys at Sheffield for the WHO. Now, this is available online, and you can go to your country of origin. Most countries have their specific tables. This is a one for South Africa. And you then only have to fill in online all the questions answered here about the risk factors as we've discussed. And you can then just press the button, and it will then give you the 10-year probability of fracture, first for a major osteoporotic fracture, in this case 11%, or for a hip fracture, which in this case is 5.3%. The more sophisticated machines will also have a software program to look at trabecular bone score, which is an easy way of an alternative way of assessing bone strength without using the bone mineral density. So unfortunately, FRAX doesn't tell us when to treat. So in the UK and Europe, they have got very good worked out interventional thresholds, which is based on their country-specific data, as well as the cost of medication and availability of medication. And this is the one that you get with the FRAX model, but it's only applicable really to the UK, and there's a separate one for Europe. Most of us people in the United States use the National Osteoporosis Foundation of the United States recommendation of fixed treatment thresholds. And the two ones here, which you will most likely know, will be when the estimated 10-year risk of fracture exceeds 20% for major osteoporotic fractures, or 3% for hip fractures, is an indication for treatment. Now, in our white paper that we developed between me and Steve for World Menopause Day, and you can get this on the website, a lot of the attention there has been put on how to interpret all these risk factors and how we can stratify risk according to a low risk of fracture, a high risk of fracture, or a very high risk of fracture. And the purpose of this is to make it easier to decide which form of therapy you'll use. In the low risk of fracture, it would be mostly lifestyle changes. In the high risk, it would probably be a bisphosphonate, denosumab, or HRT, whereas in the very high risk, we would give consideration to first using an anabolic drug. So then what constitutes low risk? So what we've put together here are all the different ways of looking at it. So the first thing for low risk is there should be no fragility fractures present. The DEXA-derived T-score should be between -1 and -2.5. And the FRAX 10-year probability should be for any major osteoporotic fracture less than 20%, for hip fracture less than 3%, or less than the country-specific threshold for intervention as in the UK and Europe. A patient will qualify for a high risk of fracture if they in the presence of a fragility fracture, a DEXA T-score being -2.5 or smaller. And in this case of high risk, it could be any one of these, not as in the first one, all of them. Then a FRAX 10-year probability of any major osteoporotic fracture of more than 20% or more than 3%, or then exceeding the country-specific threshold. And lastly, then, the very high risk, again, any of the following, where we now define the fracture as a recent fracture within the previous 1 year, multiple fractures, and the severity of the fraction. So all severe fractures or moderate fractures should actually fall into this category. a fracture while on treatment, for instance, with a bisphosphonate, a fracture while on bone toxic drugs, such as corticosteroids, and now a T-score of less than -3 at either the spine or the hip, or the frax 10-year probability of being greater than 30% or more than 4.5%, or exceeding the country-specific upper threshold for high risk, and then other factors such as an extremely high risk for falls. So what we've done, I'm just going back to the previous slide, we've taken everything and all the risk factors and put them together and stratified them into these 3 categories. Now, I'm not expecting all of you to remember everything like this, but it is available on the site, and it's more for you as well today to recognize these risk factors in order to tease out the patients that should be examined further. So the last bone of our for the past 30 years has been all the new drugs that we have developed in the past 20 years. It will be either drugs that will inhibit resorption or drugs that will stimulate formation. And this is just a timeline to show you I was involved in virtually all of these clinical trials from 1984 onwards. So as you can see here, there's been quite a lot of progress since that time. Unfortunately, at the moment, there's not really anything new in the pipeline, and that is a bit of a concern. So what then is our biggest remaining problem? And that is what's called the treatment gap. Because unfortunately, in spite of all this progress, in spite of all these tests, in spite of all the medication, the majority of patients eligible for treatment actually receives no treatment. Well, that's just the no was left out there. So I want to repeat again, the minority of patients eligible for treatment actually receives treatment. So if we have a look at this IOF, International Osteoporosis Scope report, which was published this year and reflected on the year 2019 in Europe and the UK, we see that in 2010, 55% of patients did not receive treatment, whereas now it's up to 71%. So the gap is actually being increased and not being decreased. So that is really my biggest plea today, is for you to treat the patients that are deserving of treatment, especially the ones with acute fractures. So how can we close the gap? Education of the lay public regarding bone health in general, but fracture risk identification in particular. The same for the healthcare providers. As you, I'm speaking to you today, I hope that you forget, or that you don't forget what I've said today. And then cases of osteopenia should all be further defined by the FRAX tool to identify patients at sufficient risk of fracture to warrant the use of bone-specific medication. And fracture liaison services are now being instituted all over the world. So that means that in your hospital, there will be, or there should be, a dedicated team that will look after all patients with acute fractures, especially patients with hip fractures, but even patients with Colles fractures, that they should all be investigated for osteoporosis and be put on therapy. There should also be efforts made both at the level of government and the level of third-party insurers to increase the access of patients in need of DEXA examination. And finally, the quest for new medications should continue to provide at-risk patients with effective, affordable, and safe alternatives. I thank you very much for your attention, and we now go back to Professor Goldstein.
Thank you very much, Tobie. That was an excellent overview, very comprehensive. And let me pull this up. So what I'd like to now finish up with, I think, is an important and emerging topic, and that I've entitled, "What is the Role of Muscle?" Osteoporosis, the word itself is derived from Greek roots. Osteon is bone, poros is little hole. It was first described in 1894, and through May of 2021, if you put the word osteoporosis as a keyword into PubMed, there were 93,335 articles. Sarcopenia is also derived from Greek roots, sarx meaning flesh, penia meaning loss. This was first described in 1989, and through May of 2021, the keyword sarcopenia yielded 12,068 articles. The concept of osteosarcopenia was first described in 2014, and through May of 2021, there were 126 articles in PubMed using the keyword osteosarcopenia. Sarcopenia is a syndrome characterized by progressive and generalized loss of skeletal muscle mass and strength. It increases the risk for adverse outcomes such as physical disabilities, poor quality of life, and even increased mortality. Muscle accounts for 60% of the body's protein. Muscle mass inevitably declines with aging. It can also be seen prior to aging in certain disease states, malnutrition, people who are cachectic, and certain inflammatory diseases. Unlike osteoporosis, where you just heard very well accepted definitions based very much on DEXA, bone mass measurements, and now increasingly FRAX or trabecular bone score, there really is no universally agreed upon definition of sarcopenia. In fact, it was only recognized as a disease entity in the ICD-10 of 2016. The components of sarcopenia really are those of muscle mass, muscle strength, and physical performance. And probably this definition and diagnosis of sarcopenia from the EWG-SOP, known as the European Working Group on Sarcopenia in Older People, is the most commonly accepted and what I want to share with you now. If you have low muscle mass, but still have normal muscle strength and muscle performance, this is considered pre-sarcopenic. Low muscle mass with either abnormal muscle strength or abnormal muscle performance is what defines sarcopenia. And if you've got low muscle mass with both low muscle strength and low muscle performance, this is what is defining severe sarcopenia. So how do we assess sarcopenia? It's really not so easy, as I pointed out, as lying down on a DEXA table, but there are some simple and accepted techniques. Muscle strength is most easily measured with the dynamometer, which looks at hand grip strength with this handheld device, which is then adjusted for gender and BMI. Physical performance, well, the simplest way to do this is gait speed, and being able to walk less than 0.8 meters per second over a 4 to 6 meter course is considered abnormal. Muscle mass, well, certainly the most accurate ways to measure this requires instrumentation. You can do with MRI or CT, that's expensive and involves a fair amount of X-ray. The DEXA scans do have body composition software, which can be added. And then there's bioelectrical impedance analysis, or what is known as BIA, also requires equipment, which is not cheap. But there's good evidence that you can use a surrogate that a calf circumference less than 31 centimeters is considered to be low in terms of muscle mass. So this newer concept of osteosarcopenia represents the concomitant presence of any low bone mass, whether it's osteopenic or osteoporotic with sarcopenia. And this combination results in significantly higher rates of disability, rates of falls and fracture than either entity by itself. And actually, this recent article by Sepulveda Loyola really tells us a lot about what we're talking about. They had 253 participants. The average age was 78. If they had osteosarcopenia, there was a 3-fold increase in falls and a 4-fold increase in fractures compared to those women who had osteopenia or osteoporosis alone. So in summary, in addition to prescribing the pharmacologic therapies when indicated that Tobie has so nicely talked about, what else can we do to tell our patients? Clearly, we want to optimize dietary intake of calcium and only supplement with calcium tablets if they're unable to get this by eating those foods that are rich in calcium, such as milk, yogurt, the green leafy vegetables. We clearly want to optimize blood levels of vitamin D. Vitamin D deficiency certainly can be corrected with supplements. There needs to be adequate dietary intake of protein daily, weight-bearing exercise such as walking for 30 minutes most days of the week, add balance exercises and strength training, avoid smoking, limit the amount of alcohol. And fall prevention is key as well. So we want to make sure that all rugs have a non-slip backing. You want to be sure that all walkways are well lit. You want to be mindful of slippery areas, especially if you live in a region where ice may be common. Consider wearing shoes with rubber soles. Maintain your best possible vision. Again, balance exercise and muscle building strength training. And also check to see if any of the medications that they're on may be a cause of any dizziness and thus increase their risk of falling. And with that, I want to thank you for your attention. And I guess I'll stop sharing my screen and we have time for some discussion and some questions, I hope.
Thank you, really. Thank you both, Dr. de Villiers and Dr. Goldstein, for wonderful lectures. I'm just going to comment on one thing. A few years ago at NAMS, Dr. Neil Binkley spoke, and he said the #1 reason why older people fall, besides all those things you talked about, are bifocals and progressives. And when elderly people are using bifocals and progressives, they lose their balance because they're walking down the stair, and so he said, get rid of the bifocals for the older people. So just wanted to make that additional comment. Okay, we have some excellent questions here, and I'm going to moderate them, and please feel free to ask more. And I'm going to start with a basic question, which I think everybody always wants to know, which is, for people in the low risk fracture category, what kind of lifestyle changes can be applied to help prevent osteoporosis? And what is the data to support them?
Do you want me to answer that?
Yes, why don't you start? That sounds good.
Okay, so the lifestyle changes are firstly optimization of calcium and vitamin D. As Steve put out, just remember you can measure vitamin D if you think there's a deficiency, but you can't measure calcium by blood level. It's always supposed to be the same, but you can calculate the amount of calcium that you're taking in your diet using a calcium calculator that is freely available online or at the App Store. The IOF calcium calculator is excellent. Then also it is very important to have enough protein intake, and we say that the protein intake should be 1 gram of protein per kilogram of body weight per day. Remember that the basis of bone is actually protein, which is then mineralized by calcium and phosphate to give the protein strength. The third pillar would be exercise. If you lead a sedentary lifestyle, you will certainly lose bone. So with exercise, we mean that you should do any exercise that make you battle with gravity. So that's called weight-bearing exercise. It doesn't mean that you have to run around with dumbbells in your hands. Just normal walking would be sufficient. And about 20 minutes, 5 times a week would be good, not only for your bones, but also for cardiovascular health. The other things are exactly what Stephen put out in detail in terms of your footwear and reducing the risk of falling. If you're not going to fall, you're probably not going to fracture.
I would add also, look, at least in the States and at least in my community in New York, what I have noticed is much too much reliance on a DEXA scan and then treating T-scores and using the guidelines that Tobie talked about, but not really paying attention to anything else. So for instance, if a patient has wonderful, T-scores, the doctor says, you're doing great. And if they're, meet the criteria, they want to put them on a pharmacologic agent. A third of women who break their hip do not have osteoporosis. If you have osteoporosis, your risk is that much greater. But everybody is at some risk. And therefore, all of these issues that we have talked about, whether it's maintaining adequate muscle strength, balance, all of the things that we talked about, eyesight, illumination, non-skid rugs, nothing to trip on between you and the bathroom at night, adequate calcium in the diet, vitamin D. This is why when I write the update for OBG management every year, for years I wrote an update on osteoporosis. I made them change it to update on bone health because I think people have become much too focused on bone mass measurements alone. And I'm not saying they're not important, and I'm not saying that we shouldn't follow the guidelines that we just talked about, but I absolutely think that bone health, that bone mass measurements are just one component of the overall bone health and fracture reduction, fracture risk reduction. And the things that we've been talking about are just extremely important. And I just think that most people aren't keyed into this. As people are living longer and longer and longer, this is becoming so much more of an issue.
Right. So there are a number of questions about, is this sarcopenia really a disease? And getting this word out. And somebody asked, we're doing a great job here now talking on, menopause day and osteoporosis and sarcopenia, but are men, how serious is osteosarcopenia in elderly men? Hi, Dr. Ream, that's a good question. And is this information getting out to men? Are you in touch with any of your colleagues that are making sure that geriatricians and men are getting this information as well?
Look, that's a great point. But obviously, as a gynecologist, my primary concern here, I'm talking to women all day, every day.
Right.
I'm trying to get this message out, and the audience that comes and usually listens to us, we're a menopause society, are usually taking care of women. But you're absolutely right. Although women account, as I pointed out in my first portion of the talk, to a much greater proportion of fracture than men do. Men are not immune to fracture and all the morbidity and mortality associated with fracture. Everybody is going to lose bone mass. In other words, when you ask me if sarcopenia is a disease, it is inevitable. I don't care if you are Herschel Walker, the football star. You will lose bone mass. But the way I try to explain this to my patients is that there's being a bell-shaped curve of muscle strength and muscle performance as you age. And where you fall on that bell, some of that will be genetic, but much of that will be the effort that you put in. So I say, for instance, on the far end of the bell over here is an 83-year-old woman who's a little frail, a little timid, a little unsteady on her feet. Maybe she wears bifocals. On this end of the bell, and forgive me for using an American analogy, is an 83-year-old with the fitness of Jane Fonda, who many of you will remember was the fitness guru for much of people our age. I tell my patients I want everybody from the midline to this side, not the midline to that side. And as a little analogy, I'll tell you, I had a patient recently who was 82. I was having this conversation. And this woman actually said to me, well, I am not getting a trainer or joining a gym. I'm in the arts. And I sort of rolled my eyes and I said, excuse me, do you go online? And she said, of course I go online. I said, well, if you Google balance exercise, There's a whole list of things, and there's one called 14 exercises for seniors to maintain strength and balance. I said 15 minutes a day. Think of it as Dr. Goldstein's 15 minutes, because this woman was doing absolutely.
Right.
So this is the kind of awareness that we need to start to bring to healthcare providers, to patients, and yes, Dr. Ream, to men.
Okay. Right. So yeah, there are a number of questions here, and I think there are articles written about the value of Tai Chi for balance. There's no question. Yoga also, you know, I tell people to at night when you're brushing your teeth and you've got a counter in front of you, it's a great time to brush your teeth standing on one leg. Because you can, if you get dizzy, you can fall over and hold on to the counter or the sink. But really, you really have to be able to stand on one leg for a period of time so you don't trip or fall over. Okay, somebody asked, should we be doing routine body compositions with our DEXA scans, which I know, you know, is a topic for discussion. It could be something you could add on as far as your DEXA scan.
So look, I think it would be wonderful if we had great standardization, if we had the ability to have that on all equipment. The software is not inexpensive. The interpretation is not easy. We started to do some of this. I'm not even 100% sure of the reliability, the reproducibility at this point. We're really looking through what we call in the States Coke bottle glasses. I mean, we're in the infancy, I think, of this. So the first step is an awareness. I think the first step is thinking about this, getting patients and healthcare providers to not only be looking at bone mass measurements, but thinking about muscle performance, muscle strength, muscle mass.
Fall prevention.
And I think that what will follow will be better studies, better methodologies, more standardization. But we're really at the infancy of this.
Okay. Dr. de Villiers, what do you say about this? A few people are asking, should the treatment be based on country-specific developed T-scores or Z-scores? And then there are a number of questions about Z-scores. Can you talk a little bit about both of those topics? Okay,
So your T-score and your Z-score is a DEXA-derived term. So we, although there are country-specific models for that from the ISCD, we actually all use what we call the NHANES2 database. So that is being used worldwide. And we also do not use specific values for males and females. We actually all follow the female values, even with males, for determining the T-score or the Z-score. On the other hand, when we use those scores and we want to apply it to the FRAX model to get a prediction of risk over the next 10 years, you then need country-specific values, and that is derived by looking at the hip fracture incidence in that particular country, as well as the mortality figures linked with that. So we, to put it in short, we use the NHANES2 database for the DEXA machines, but we use country-specific values for calculating the FRAX risk.
Right. So a follow-up question to that, and this is really a great question. When interpreting the DEXA scan in patient with POI, premature ovarian insufficiency, would you use a T-score? Because this person says they're postmenopausal, but they're younger than 50, most of these women. Or would you use a Z-score because they're younger women, a 35-year-old with POI? Do they use a Z-score or do they use a T-score?
The short answer to that is in POI, or when you think that the patient is menopausal, irrespective of her age, you will use the T-score and not the Z-score, because the patient will not be progressing up and gaining more weight. So she is seen as a postmenopausal woman. So you use the T-score there. And for all men after 50, you also use the T-score and not the Z-score.
Okay, that's okay. So some of the other questions here are somewhat near and dear to my heart about the use of hormone therapy. and thanking everybody for these excellent lectures. And at what age, we know what the guidelines show, but do you feel that all women should have a DEXA scan when they reach menopause in the ideal world? And they also want to know that, you know, do you feel, as this person does, and I do, that virtually all osteoporosis can somewhat be modified or prevented or dealt with if one were to think about menopausal hormone therapy and give that some attention, especially in that younger, newly menopausal woman, because this would be, for most women, quite an appropriate way to prevent, you know, what we've learned is so much of that bone loss happens early on in preventing or treating osteoporosis. If there's no contraindication.
Right. I will handle the hormone question first, because I want Tobie to talk a little bit about the guidelines for DEXA scanning, I think. But I think you hit the nail on the head. What is often lost in my non-gynecologic colleagues is just how good a drug estrogen is. You know, all of these bone drugs that have been developed, you know, in order to get approved, had to show that they reduced fracture, and the labeling on HRT or HT doesn't talk about fracture reduction, because they never really did fracture studies. It all talks about fracture prevention or osteoporosis prevention. Yet those of us in the field, when you look at the Women's Health Initiative, these women were not chosen for any risk of bone. There was no DEXA scan performed. So of 15,000 women in each group, I'm sure some had normal bone, some had low bone mass or osteopenia, some had osteoporosis. Yet there was a statistically significant reduction in hip fracture in both groups. You know, you look at, in order to prove hip fracture reduction with some of the bisphosphonates, they had to call out the most high-risk women. In FIT1, they took women who had osteoporosis and at least one pre-existing vertebral fracture in order to show a statistically significant reduction in hip fracture. Estrogen is an excellent bone drug. And I think if there were some questions in the chat also about some of these secondary causes that are hypoestrogenic, Turner syndrome, or, you know, gonadal dysgenesis, or anorexia nervosa, premature ovarian failure. I mean,
there's a lot of questions about POI here, and I think
getting estrogen.
There's no question.
Estrogen, you know, and
anybody, and I'm surgical menopause without contraindication. If it's, you know,
non-gynecologic colleagues will just do not prescribe estrogen for anybody, and it's a shame, because it really is an excellent drug when used appropriately. And so much of the negative connotations that what came out of the WHI that were uncalled for at this point, you know, we're not starting women who are 63 devoid of symptoms on hormone therapy in order to prevent cardiovascular disease, which is what the WHI was all about. So, you know.
Right, I agree. So do you, the other part of that question was, let's see, it had to do with the, when do you think we should start doing DEXA scans despite all these guidelines?
Okay, so I have to stand by the point of the International Osteoporosis Federation, who does not, or foundation, who does not feel that a blanket approach of DEXA at the age of 50 is indicated. But they do feel that at the age of 65, whether you're female or male, that you should have at least your first DEXA examination. So who then should be screened at menopause? Well, menopause is one of the risk factors for fracture, but you should have a look at the list that I gave earlier. And if you have 2 to 3 of those factors present, and you are not routinely going on to menopausal hormone therapy, then it's a good idea to have a DEXA. But we should just always remember bone mineral density, or DEXA, is one of the risk factors for fracture. And you can actually use the FRAX model without a DEXA bone densitometry. You can fill it in without that, and will still give you an idea of the risk prediction. And if you feel that it's warranted on that, you can then move forward. So in an ideal world where there are enough DEXA machines available. Maybe it could have been, or you can consider doing it for all patients at menopause. But really, the availability of DEXA is poor in many parts of the world. And there you will, in any case, have to deal with the risk factors alone without DEXA.
Yeah,
Well-
the use of FRAX without DEXA as an indicator of risk is an excellent idea, especially if it's difficult to obtain a DEXA. I think the entire other side of that spectrum is in very high resource areas of the world. You often have patients who are asking for bone mineral density testing, who are plugged into this, and they get to be 50 or 55 and they want to have a DEXA scan and they don't really have a whole lot of risk. And I think a lot of healthcare providers acquiesce and will order this. So, I have less of a problem in obtaining this as long as you don't overtreat young women. A woman who's newly menopausal with low bone mass, if she didn't have any secondary cause, likely never peaked her bone mass like her peer group. So, if this is going to motivate somebody to do the lifestyle changes that we've talked about, that's great. But if we're going to start over-treating younger women, and that was one of the biggest advantages of FRAX, in a lecture that I used to give, it was called Osteoporosis for the Generalist, I gave 2 examples where FRAX was going to help a lot, because there tends to be, before that, if you simply use T-scores, there was over-treatment of younger women and under-treatment of older women, because you understand much of this risk is age-related.
Right.
An 80-year-old with a T-score of -1 has the same fracture risk, if you use T-scores only, as a 50-year-old with a T-score of -3. And most people, if they do order a DEXA and a 50-year-old has a T-score of -3, they're going to put her on a drug. An 80-year-old has -1. They say, you're doing great. They both have the same 10-year fracture risk if everything else is the same. So I think that you need to be careful not to inappropriately treat younger women if you do get cajoled into getting a baseline scan in high resource areas.
And making sure these women understand that baseline scan with a negative number doesn't mean you've lost all that. I mean, that's the part that people don't understand. The worried, well, healthy women think they're negative, and they may never have reached a peak bone mass. So what about, let's address some aromatase inhibitors on the effect on bone. And we have so many women. You talked about breast cancer, Dr. Goldstein, and could you both comment about the management with aromatase inhibitors and what you're recommending even for younger women?
Okay, maybe I'll answer that one. Aromatase inhibitors obviously will have an effect on bone, whether the patient is premenopausal or menopausal, but mostly it's given to postmenopausal women who has estrogen and progesterone receptor positive breast cancer. So we do in our unit, as a matter of routine, before we put those patients on the aromatase inhibitor, we will have a look at the bone mineral density. If the bone mineral density is very low to start off with, we may rather consider to use tamoxifen, which hasn't got a negative effect on bone in the postmenopausal women and has maybe not exactly the same effects on the breast cancer, but it's still one of the cornerstones of treatment in many parts of the world. If a patient goes with a normal bone mineral density initially on the aromatase inhibitor, the DEXA has to be repeated after a year. And if there's any significant drop in bone mineral density, it is in order to offer the patient a bone-specific treatment as well. And in this regard, both the bisphosphonates and denosumab have been shown to have a good utility. So be very careful for a patient on aromatase inhibitors. They do have a higher instance of fracture, which was shown in 2 and 3 large randomized trials.
In my community, there's no question. I think that there's an overutilization of aromatase inhibitors in young women who have early disease, or I mean, they are wonderful drugs. They will save lives in people who may have more advanced breast cancers. But the use of them in stage 1, and now they're even calling DCIS in my neighborhood stage 0 breast cancer, and it's not invasive. I had a patient the other day who they wanted to put on an aromatase inhibitor because she had dense breasts and they couldn't interpret the imaging. It's out of control. And I agree with Tobie, tamoxifen is an excellent drug for many, many of these women. Having said that, there was a good study with denosumab and aromatase inhibitors that showed not just bone mineral density data, which they do have with IV zoledronic acid showing an improvement, but with denosumab, people who started with normal bone mass, osteopenic bone mass, or osteoporotic, all 3 groups had a statistically significant reduction in fracture who were on aromatase inhibitors who used denosumab. So I do think women on aromatase inhibitors, it's a unique situation, and I would perhaps use different criteria for who I would treat. I'm inclined to give, based on that data, denosumab to almost any woman who is on an aromatase inhibitor, even if she doesn't yet have low bone mass, based on that data that I just quoted.
So one thing just to remind everybody, though, is that if you use tamoxifen, which we do on premenopausal women, it's going to have a negative effect on bone. So I just wanted that as a little pearl here as well. All right, so I have one other question related to, we're talking about the GnRH agonists, because what they're doing is putting younger women and then putting them on an AI. And women who have induced menopause by GnRH agonists, we have a good question here. When would you consider a DEXA? And would you repeat the DEXA at intervals if the patient was on appropriate add-back HT?
Well, I think that in a young patient, it is indeed an indication to do a DEXA at the start of therapy. And it is hardly ever, except in glucocorticoid-induced osteoporosis, necessary to do a repeat within 1 year, because the changes are just not expected to be significant in that shorter period of time. So then I would, depending on the value of the first one and the intended duration of the use of the GnRH agonist or antagonist, whatever you use, to determine the follow-up interval, but it would definitely not be less than 1 year, and would more likely be 18 months to 2 years for the follow-up. But I mean,
but if they're on add-back therapy, most people I don't think really do both DEXAs, because there's studies showing add-back therapy is enough to prevent bone loss.
Yeah, but that's add-back therapy that you put for patients on endometriosis. And it's not for the breast cancer patient that we are discussing at the moment.
Well, this was a different question. It was a follow-up, or this question wasn't related to the breast cancer patient.
The newer GnRH antagonists that have add-back built into them are really only approved for 24 months. So I don't think it's that much of an issue in their premenopausal. I want to make a comment, because something Tobie said just reminded me of something that, and hopefully the people listening to this, if you all know it, that's great. And if you don't know it, it's important. The plus or minus in the spine on a DEXA scan is about 3% in a good lab and as much as 5% in the hip. And I can't tell you the number of people I've seen over the years who have had a DEXA and they're put on a medication, and then somebody gets a follow-up scan. They gain 2% in the hip and spine, and the doctor says, you're doing great. They lose 2% in the hip and spine, and they say, oh my God, we've got to add another drug or change drugs. What people don't understand is both of those women are unchanged. Both of those women are within the standard deviation of the equipment's capability. So be careful about, I had a lady yesterday, T-score was minus 2.5 and went to minus 2.4. And she said, well, it improved. And I said, well, actually, it's unchanged.
Right. People should be doing precision studies on your machines and what is known as what is statistically significant. And unfortunately, most centers aren't doing those. So it's a real challenge, which then brings up, people wanted to comment here about degenerative changes in the inaccuracy. How do you handle that? And the inaccuracy, especially of looking at the lumbar spine. And people get a T-score that looks great, when in reality, and they say to the patient, and they've had a fragility fracture. So could you comment on all of that?
Okay, so once you just realize that as you get older, the value at the level of the spine L1 to L4 becomes very unreliable. And it may even just by the normal sclerotic or the changes, it can actually increase without you doing anything. You should also realize that if you're not specifically looking at fractures and you including a fracture in your reading, that would also falsely elevate your reading. But that doesn't happen at the hip. So your best indicator in a patient where you suspect has sclerotic changes is to do the hip. And if you follow it up to use the total hip and not only the femur neck. If we have a look at the FRAX model, for instance, it only uses the femur neck. It doesn't take into account the vertebral values at all for that particular reason. Although some people see that as being a disadvantage of the FRAX model. But the trabecular bone score, though, that you can combine with that, takes into account the strength of the vertebrae irrespective of the bone mineral density reading. So I always think it's a good idea to combine that. Then the third thing just to remember, you often have an elderly patient where you don't trust the spine values and the patient has maybe had bilateral hip replacements already for rheumatoid arthritis or arthritic changes. So in those cases, you should also add the distal third of the forearm. And although it's not such an accurate one under those circumstances, you would treat the patient according to the lowest value of the distal third of the forearm or then the spine value.
Okay, that's a great summary. Let's change the topic a little bit here. And somebody's asking, because I know in certain countries this is quite popular, besides recommending, vitamin D3 to make sure that you're vitamin D replete, and remember, sunscreen will block your ability to make vitamin D in your skin, so most people do need some vitamin D. What about K2? Any comments on K2?
Steve, I can just add a general comment. Now, K2 became popular as an additive to D3 and calcium in the wake of the work from the Auckland group in New Zealand, which actually showed that too much calcium can cause coronary arterial disease. And so the K2 was then brought in by some companies and by some researchers as a preventative measure to prevent the blood vessels from coronary arterial disease caused by too much calcium. But I'm afraid that was an oversimplification of quite a few factors. Firstly, nobody is actually quite sure that taking too much calcium supplementation will indeed cause coronary arterial disease. I know that the Auckland group, Professor Ian Reid and them actually feel very strongly about it, but one should really understand the work to understand why there is some controversy about that. So as far as I am concerned, I really could look at the literature about 3-4 years ago. After such a question, I'm not convinced that it is necessary to add K2 to calcium supplementation, and specifically not to protect the coronary arteries.
Okay, that's a great summary. And then how do you follow up the efficacy of osteoporosis treatments? And what would be your interval for doing a DEXA, but more importantly about bone markers? Do you follow the C-tylopeptide or any of the bone markers of bone turnover?
So let's first make it simple. Your best indicator of success of treatment is when when a fracture doesn't occur. So if the patient doesn't fracture while on treatment, it's already a great great success that you've achieved. Secondly, using the DEXA scan, as you've both alluded to in little bits of pieces, there are a change for every machine that's called the change of least significance. So for every machine, if you measure the same patient a couple of times a day, you will get a variance. So on most machines, it will have to exceed a change of about 2.5% before at the spine, and even more, 3.5% at the hip before it will be significant. But that will be dependent on the type of machine and the operator using the machine. So firstly, you have to understand that a little bit of change, as Steve said, is not necessarily significant. The third point that goes with it is that you should interpret these tests according to the expected change caused by the specific drug. And that's what people don't understand, is that if you're using a bisphosphonate, which is still the most commonly used drug, you can expect in the first 2 to 3 years an increase in bone density of around about 1% as a rule of thumb. But after 3%, 3 years, it will plateau and you will have no further increase. And that's because you're only inhibiting a resorption. And after about 3 years, you'll probably also inhibit a little bit of the osteoblast. But that doesn't mean that you're not having protection yet. So even if it just stays the same after 3 years, it is still being effective treatment. That is in the exact opposite, or not the exact opposite, but a different drug will have different expectations. Such as denosumab, you are expected to see an increase per year, irrespective of how long you be. And that's where the treat to target comes from. You can use denosumab until you reach a target. And although there's no official target, a reasonable target would be a t-score of -1.5 at the particular region which had been the lowest, and that prompted you to start with your treatment. And that's being suggested by Dr. Ferrari of Switzerland. So there are many things to look at it, but as I said before, never do it in less than 1 year, the follow-up visit, except if a patient goes on high doses of corticosteroids for an extended period of time. There you have to repeat after 6 months.
So, and my understanding is that the reduction in fractures with most of these agents is far greater than one would predict based on the modest improvements in bone mineral density. And we understand that there is bone remodeling. In other words, microarchitecture is not measured by your DEXA scan. And I explain this to patients, but unfortunately, you have to understand when patients are given a drug for high blood pressure, they want to know what's my blood pressure. When they're given a drug for cholesterol, they want to know what's my cholesterol. You know, if you've given them a drug because they're at risk for fracture and they want to know, well, is it working?
So this participant asked, do you follow CETP of any markers of bone turnover?
Well, I think in my case, I would have deferred to what Tobie said in the sense that the lack of fracture, in other words, a lot of this is taken based on the science, and I don't necessarily follow that at all. I think it's important that patients understand this. The one reason to possibly get a follow-up DEXA on some of these patients is if there's a significant drop on these medications, then you start to think about, could there be a secondary cause of osteoporosis, and does there need to be more of a metabolic workup? Because certainly I, as a gynecologist, am not really handling and doing much about secondary osteoporosis. I have people in my colleagues of mine who only do bone metabolic work. And so if I suspect a secondary cause, I will usually refer this to somebody. And I would like to get every, healthcare provider of women, generalist provider, to just be thinking about, in those rare instances where there may be secondary causes, this should be perhaps referred to somebody who does this, because almost all of what we deal with is garden variety, lack of estrogen, menopause, aging, bone loss. And that's the meat and potatoes of what we're talking about. But there are, as Tobie pointed out, secondary causes which you have to start to think about if there's a lot of drop on medication.
Right. And some people have had some screening prior to go on meds for ruling out secondary causes, because it would be terrible to be on a med and then a year or two later you find out the person is not responding. Many people, though, who don't have a change or stabilization in their DEXA, or you find out they're non-compliant or they're not absorbing a certain generic bisphosphonate or taking it right. So there may be a role for looking at there are people that follow CETP. I guess that's what I have to say, or other markers of bone turnover. So Tobie, there was a question here about the role of, bone turnover, and is there a differential between cortical bone and trabecular bone? And any comments on that?
I'm not quite sure whether I understand the question correctly, but the question, as I understand it, is about markers of bone turnover. Markers of bone turnover do not necessarily discern between cortical and trabecular bone, but they do show us we do have two different types of markers, and it will be the markers of bone formation or the markers of bone breakdown, and they both go up as the bone turnover increases during osteoporosis, the process of osteoporosis, and bone remodeling is going at a faster speed. So I don't see much of a role in the routine patient for doing bone markers, but they are very good at telling you whether the patient's actually sticking to the medication, because that's a big problem in osteoporosis, is compliance of patients to medication. So you can use your bone turnover markers and the response on them to determine whether the patient is in fact using the medication. So in many clinical studies, that is routinely being used. And in clinical practice, though, I find that the biggest place where I use markers of bone turnover will be again in the younger patient, where you're not sure whether she presents with a genetically determined low peak bone mass, or whether she's actually in the process of actively losing bone. So if you have a younger patient with a low bone density and perhaps a fracture, but the bone markers are normal, then you are probably not dealing with an active process of bone loss. I can also just add to this that we're mostly speaking to generalists today and not to bone metabolic experts. Steve has already alluded to this. But I wouldn't even advise the generalist to do a bone mineral density test on a premenopausal woman. It should be very carefully chosen patients, and the results should always be reviewed by a bone metabolic expert, as it can be extremely difficult. There is virtually always a secondary cause present, and the use of medication or the standard bone medications becomes very tricky, especially in patients of reproductive age. So leave that to the experts. There are very few of them around. It is also important to remember that, as I said before, the diagnosis of osteoporosis in the young woman is never made on bone density alone. It will be a combination of low bone density as well as normally more than one fracture.
Okay.
That would be the. I hope I answered the one on bone markers of bone turnover correctly. I don't bring that really to trabecular and cortical bone.
That was a different question. Somebody here was very interested in knowing, is there a differential loss as we age in menopausal women between trabecular bone and cortical bone? Which I think is a good comment, because we know go ahead.
Sorry. I can, the first two, when you lose estrogen soon after menopause or directly after menopause, it will always be trabecular bone that will first be lost. And that's why your in the younger menopausal patient, the DEXA estimation of the vertebrae of the spine will show the changes first. And that is exactly the opposite to the older patient, where it will be more of a loss of trabecular bone. So it is important to differentiate between that. And that's also why people who don't like the FRAX model says, well, it's not that useful in the younger menopausal patient because it doesn't take into account the vertebral values. It only takes into account the cortical values really of the hip.
Okay, that's wonderful. Okay, we've got lots of good questions still coming, which is so wonderful here. Somebody commented here about the role of bariatric surgery, and shouldn't that be included as a risk factor when you list your risk factors? And could you comment on what happens when people have bariatric surgery and the effect on bone? And I know there's some issues with vitamin D absorption for some people.
I really have very little experience. I mean, there's a double-edged sword there. We know that people, people who are a little rotund tend to have less bone loss. All that adipose tissue is making estrone for many of those women. So, but you're right. I mean, this is a unique subgroup, and I think that vitamin D absorption would be quite important. And
right.
These unique subgroups, it would be helpful if the people who do the bariatric surgery were more attuned to these issues, because they have the ear of these people, and they should be the ones who are initiating the counseling about, you know, the do's and don'ts that go along with that kind of surgery, what those their patients need to be on the lookout for and be aware of.
Right. Okay. This is another topic. I think we have a few more minutes here, and then I think it's been announced that this will be on YouTube, and we're going to continue on our discussion at our IMS 18th World Congress, everybody, in October 26th to 29th in Portugal, Lisbon. So we're looking forward to that. But I did want to ask one comment about, yeah, that's a great picture. It's getting everyone excited. About drug holidays, before when you were talking about denosumab, I want to make sure that everybody knows in this audience that when we talk about drug holidays, you must follow denosumab, like with a bisphosphonate, because if you take denosumab or an anabolic agent and stop it, like estrogen, you lose bone. So.
Well, more so, you don't just lose bone. There's evidence that with the cessation of denosumab, there's a rebound effect in terms of vertebral fracture. So I'm sure that any of my patients that are on denosumab are aware of the fact that they really have to be compliant with its utilization, because if not, having said that, you know, when people are put on, you know, a statin, they don't come off that if they're doing well. And if they're put on something for blood pressure, they don't come off that if they're doing well. So if somebody, and that's one of the reasons why I don't favor denosumab in younger women, because I kind of look upon that, if people are doing well, as something that they're going to do indefinitely.
Well, there is a lot of discussion here about drug holidays with bisphosphonates. So maybe, Tobie, do you want to just make a comment about that?
Yeah. The whole idea of a drug holiday for bisphosphonate is actually unique to a bisphosphonate, and that is that the bisphosphonates bind to the hydroxyapatite of bone very strongly. So once you stop treatment, it's like the giver that continues giving. There will still be, I'm sorry about that. I'm still in clinical practice, so the phone never stops. But so even if you stop, there will still be at that for a reasonable period after that, active metabolites of the drug doing the job. So that's the first thing. The second thing is that we do get two common complications, or not common, but two complications with bisphosphonate therapy, and the one's called the osteonecrosis of the jaw, and the other one's the atypical femur shaft fracture. And both of these are somehow connected to the length of treatment. So we don't want to use the bisphosphonates for too long. And we also know that we can interrupt them and they will still work for a while. So as a rule of thumb, on oral treatment, you should consider a drug holiday after 5 years, or on intravenous xylandronic acid, you should reconsider that after 3 years. If the need for therapy is still there after 5 or 3 years, look at changing to another drug, and in many cases, that would then be denosumab. I just want to add to denosumab that one of the bigger problems that we that specialize in bone metabolic health is that a lot of our patients that we see are patients coming from the nephrologist or the renal units. And because denosumab is not metabolized by the kidney and your bisphosphonate is, bisphosphonates are relatively or sometimes absolutely contraindicated in these patients from the renal unit. So we put them on denosumab. But what do you do when you stop it? You can't plug it. We call plugging the denosumab. You can't plug it with the bisphosphonate. So that brings you into quite a difficult situation. Steve, that's where estrogen sometimes comes in very handy.
Absolutely. I mean,
so it becomes really difficult when you're dealing with other causes of bone metabolic disease and not just the normal garden variety, as Steve alluded to. So just remember, 5 years oral, 3 years IV, and consider whether you should go on mostly a 2 to 3 year break, and then you can consider resuming the bisphosphonate, and it works quite well.
Okay.
But I wanted to make one other comment, which is we know that estrogen promotes lean body mass, and stay tuned, because I think in the next decade, we're going to see a lot of research showing the crosstalk between bone and muscle.
Okay, that's a great way to end. And there were questions about the role of estrogen on the muscle and the fat and the bone. So we'll get on. And if you come to the IMS meeting, we'll be bound to have more sessions on this. So thank you, Tobie, Steve, everyone who came to us today. We had lots of people on. They're all getting busy now. I hope you'll all go out and take a walk now. And remember what I told you about your balance and making sure you can stand on one leg so you don't fall. And really with that, I think we'll wrap things up. And thank you for being with us here today.
Risa, thank you for getting up so early on the West Coast of the US to do this.
Okay. All right, I did it. Okay. All right. Well, we're just starting our day here at 7:30 in the morning. So we'll carry on to the future of bone health.
All right.
Take care, everybody. Bye-bye.